All right, well, welcome back to Ultrasound Grand Rounds again this week. I'm really excited to be back here. As of last time that we talked or we got together, I was going to be going to AIUM in Austin, Texas, and I'm now back. It's been a couple weeks since I've been there, but what an amazing conference. Every year, just good speakers. There's a couple really interesting plenary sessions that brought a broader perspective to the whole ultrasound thing. And then my favorite part of this whole thing is just the ability to meet with and engage with other members of the POCUS community, both people who I've known for quite some time, who I would consider great friends, as well as new people that are joining the POCUS community. And what was especially fun this time is meeting a number of the people that follow us on this YouTube channel. And so for those of you guys who went to the conference, who reached out, thanks. It was really fun meeting you guys. And I look forward to seeing you guys maybe at future conferences in future years. And I think the next time we as a group are going to be at a conference will be probably SAEM coming up next month. So if you're out there, look for us. Otherwise, we will see you, at some future conference. So anyway, with that being said, we are going to transition over today to our topic of choice today. And so we're going to continue on with that obstetrics theme. And I know about a month ago, I gave a presentation about the normal first trimester ultrasound, basically set a stage and set a framework for what are we looking for kind of as a patient presents to the emergency department when we do the ultrasound, right? And so that kind of set a baseline. And now we're going to build on that, right? And Dr. Sandy Werner is joining us today, and she's going to talk a little bit about some abnormal findings in the first trimester. But as you guys know, Sandy has been on this channel before. She is currently our fellowship director for our ultrasound fellowship. Before she gets started, I just want to have her talk a little bit about our fellowship, because I know we're getting kind of close to and up to application season here pretty soon. So as you are a resident thinking about potentially what you're going to do afterwards, consider doing an ultrasound fellowship and considering it do at Metro. So with that being said, Sandy, tell us a little bit about the fellowship here.
All right. Thanks, Matt, for having me up into the studio today. So we offer a 1-year ultrasound fellowship in Cleveland, which, as you know, is now the place to come to. We have ultrasound machines in every ED. We have 3 community EDs. We have the main ED, and we have a bunch of ultrasounds there. We have an active TEE program that we do peri-arrest. So we're doing not only cardiac arrest, but also really unstable patients who might be in and out of arrest. We have an active nerve block program. We're doing them in the ED, and we're also doing some up on the trauma floors to assist them in combination with our anesthesia colleagues. And we do all of the basic scans. We're an ED that sees pediatric patients as well as adults, so we pretty much do everything. So if you're thinking about ultrasound, Cleveland's a great place to live, cool cost of living, and lots of good school districts if that's important to you. And we have great ultrasound faculty. We're a good place to train. So come on out. Apply to us.
Sounds good. So yeah, if you want to train with us, if you like what you're seeing on the ultrasound channel here, we'd love to have you. So send in an application. Sandy, how do we apply to the fellowship?
So the applications are through their SCUF runs the application process, but basically you're going to apply through the ACGME. And then we'll get your applications that way. So it's going to be through it's the NRMP process. So you'll put in application sort of like you did when you were a resident, but the time frame is different. So it actually starts in early fall, and we will open it up. You'll put your applications in, and then those that are applying to us, we'll get your applications, we'll review them, we'll invite you for an interview, and then the whole process is done sometime in October. So you'll be matched for the following year.
Sounds good. And if you want more information about us, metrohealth.org/POCUS gets us to our website. And then from there, you can branch out to our social media. You can get in contact with us. So anyway, with that being said, let's turn things over and let's actually talk a little ultrasound today. So Sandy, tell us a little bit about the first trimester ultrasound, the abnormal findings there. Go ahead.
All right. Well, so Matt posted this as abnormal findings. And, I kind of noticed that Matt gets a lot of the normal stuff. And so I didn't really want to say they're abnormal, because some of them are not really abnormal. They're just variations on a theme. So we're going to call this not quite your normal first trimester ultrasound. So I don't have any disclosures like many of the rest of you. So our objectives are to review the progression of a normal pregnancy, because it's been a couple weeks since Matt talked about this. And we'll talk about twin pregnancies, multiple gestations, and then some pathology, including subchorionic hemorrhages, pregnancy failure, moles, and pregnancies of unknown location where we're playing hide and seek. So I want to just review the transvaginal ultrasound basics, because a number of the images and videos in this lecture are actually transvaginal. So in order so that you understand the orientation, we're going to go through that pretty quickly. So for and transvaginal ultrasound, we use an endocavitary transducer, and you want to get in the habit of calling it an endocavitary transducer, because lots of us use these for peritonsillar abscess drainage. And if you walk in there and say, oh, I have my transvaginal transducer, I guarantee you that there's no way you are going to be doing peritonsillar drainage with ultrasound. So just get used to calling it the endocavitary transducer. Okay, so what happens with our endocavitary transducer? Well, the patient is actually, they're supine, so we're going to be inserting the transducer into the vaginal canal. So we're not looking at the patient from anterior to posterior, but we're looking caudal to cephalad. And, if our screens were tilted 90 degrees clockwise, this is the image that you would see in the sagittal plane. So you would see the head up at the top or the left of the screen, anterior would be at the top, posterior would be at the bottom, and then caudal would be where your transducer is. Unfortunately, our screens are not set up that way. They're actually rotated. So you have to do a little mental gymnastics, or perhaps it's a mental geometry, so that you can get the orientation. So now anterior is on the left side of our screen. So you can see with the thumbs up, you're at the 12 o'clock position, and the uterus is going to appear. And this is a normal anteverted uterus. I'm not going to go into what happens when the uterus is retroverted. We can save that for a later talk. So the cervix will be on the right side of the screen. The fundus will be on the left side of the screen, and then caudal will be at the top and cephalad will be at the bottom. And you can see there's the fundus, there's the cervix, and there is the endometrial stripe, a nice thin stripe, which is expected in a normal, non-gravid uterus. So to get the coronal, or sometimes you'll see this as a transverse view, you just turn the probe 90 degrees to the patient's right. So you're going to go from 12 o'clock to 9 o'clock. And then you'll see the uterus just in cross section. It looks a little bit like a donut, where we have the myometrium, kind of lower level echoes, and it's surrounding the endometrial stripe. And obviously, if there's a pregnancy, it will be kind of eccentric to the endometrial stripe. So that's what you kind of need to know about transvaginal scanning. And I'll try and point out which scans are transabdominal and which are transvaginal as we go along to help keep you oriented. So first, we have to do a brief recap, because it's been a couple weeks since Matt talked about normal pregnancies. So we're going to talk about just reminding you that usually we like the pregnancy to be in the fundal location, although, it becomes in the body as well as it progresses along. We don't want to see it down by the cervix. When it starts, we want it to be sort of eccentric to the endometrial canal. So we want the gestational sac just off the stripe, the endometrial stripe. And of course, we want adequate myometrium surrounding the gestational sac. And this is very important when the fetus is very high in the fundus, because you have to worry about whether or not it's actually in the uterus or right at the edge, like a cornual ectopic. And then, of course, we want to make sure that the pregnancy is viable. And you can see this little pregnancy on the right. It's got a heartbeat. It's got a yolk sac. You can see it's got a nice gestational sac around it. Everything looks good. So normal development, as Matt went through a couple of weeks ago. So basically you start out with a decidual sac or the gestational sac. And you can see in the image on the upper right how this little tiny decidual sac is eccentric to that midline of the endometrial stripe. So there's a bright white endometrial stripe, and the endometrium is starting to expand to accommodate the pregnancy, and then you can see the little sac developing. And as it continues to develop, it gets this thick layer of endometrium around it. It may have a double sac sign, and that happens like 4.5 to 5 weeks. And you can see that in the picture below. And typically it's going to be almond-shaped or circular. And then, of course, the next thing we get is the yolk sac. And this is a transvaginal view. So it's transvaginal, coronal, or transverse. And you can see there's a nice, healthy uterus surrounding a Cheerio. And you can almost see little fetus developing, the kind of diamond ring happening right there. So this will happen 4 to 5 or 5.5 to 6 weeks. And then really after about 6 weeks, you start to see the fetus, and sometimes even earlier than that. And then the fetal heart rate is generally seen with fetuses who are 7 millimeters or larger. And really, often you can see the fetal heart rate when the fetus is even 3, 4, 5 millimeters. So it's not really, you'll see it much earlier. A lot of these standards were kind of made when the ultrasound machines were not so good, but now sometimes you can see a flicker even before you can actually measure a crown rump length. So that can be seen a lot earlier sometimes. And this is just a reminder that when you measure the crown rump length, you do not include the yolk sac. You just include the fetus, and you get it in the longest plane possible. Oops. So this is great. This is what we hope is happening. We're getting our little fetus saying, "Hi, Mom." Everything's developing normally. We're, like maybe 13, 14 weeks here. But, it's not always normal, or sometimes it's a variant. So we're going to go through several scenarios. You'll get tired of this G2P1 patient at maybe 8 weeks with spotting. A couple variations on there. So we have a patient. They're at about 8 weeks. They're having some spotting, and we take a look with the ultrasound. This is a transabdominal view, and you can see the fetus is moving. You can see the umbilical cord there. You can see there's actually a fetal heart rate, and so it's kind of like, okay, well, why are they bleeding? Everything looks pretty good. And then, we're kind of scan through, and you should notice that there's this anechoic space that seems to be within the gestational sac, but it's sort of like outside of the chorionic space. And so you're wondering, what's going on there? So what this is, it's a subchorionic hematoma. And these develop because the edge of the placenta lifts up, and we don't know really why, and bleeds a little bit. And sometimes they can be here, sometimes it could be down here. And you start to get bleeding when this blood seeps down towards the cervix, and someone will come in with spotting. And most of the time, these are actually pretty common in the first trimester of the pregnancy. And most of the time, they're benign. They heal up on their own. So no big deal. So when you see one of these, it's small, they're having some spotting, you can generally reassure them that everything is going to be okay. And how echogenic they are depends on how long they've been there. So just like any blood, like when you have a fast exam, at first it's really anechoic, like the picture in the upper left. But as it progresses and it starts to clot, it's going to become more echogenic. So you'll notice some variation in the echogenicity of these subchorionic hemorrhages. And size does matter. So you can see that this is a really large subchorionic hemorrhage. It actually, it crosses the cervix. It's all the way up and around here. And so it's quite extensive. And it's probably more than 50% of the way around the pregnancy, the gestational sac. And this is concerning because at this point, the pregnancy is at much higher risk for miscarriage. So if they're really large, they're at higher risk for miscarriage. If they're smaller, no big deal, but this is just something that you want to discuss with the patient. Most of the times these are small. This is like not a big deal. In this particular patient, they did go on to have a miscarriage with this size of a subchorionic hemorrhage. So we have our G2P1 patient, and this one's actually at approximately 11 weeks with spotting. So change it up just a tiny bit. So, and we look, and we're in the transabdominal plane, and there's a giant sac there, kind of moon-shaped, or maybe that's debris, or maybe that's a placenta. I'm not really sure. There might be some little echoes in there, but I'm not really seeing much. And it's really big. And I'm thinking, well, that's kind of abnormal because, I ought to see something with a gestational sac that measures out to where it should be 9 weeks and 1 day. But, what do I tell the patient? Can I definitely say this is a fetal demise or a failed pregnancy? Or, where does that stand? And actually, there are some criteria. So this is actually from a New England Journal of Medicine article. This was from a multi-specialty consensus conference on early first trimester diagnosis of miscarriage and exclusion of viable pregnancy. These guidelines, before they were based on much less accurate and lower tech ultrasound machines. So they went through and they updated this about 12 years ago. So for us, the most important things when you can actually diagnose that the pregnancy has failed is if you have a crown rump length of greater or equal to 7 millimeters and no heartbeat, or a mean sac diameter of greater than equal to 25 millimeters and no embryo. And then, of course, if somebody's coming in for a repeat scan, you'll have to think about what they had, 2 weeks before, look up if they had an old scan, and if suddenly they don't have an embryo, but 2 weeks ago they had something that was a yolk sac, then that's a definite pregnancy failure. And then if there's no embryo 11 days or more after a scan that had a gestational sac with a yolk sac, again, we can clearly say that's a pregnancy failure. And then on the other column are the findings that are suspicious for but not diagnostic of pregnancy failure. So this is, it's tough because when you're talking to the patient and they have one of these, you have to sort of say, well, this might not develop, but it might, because we don't really know. It's not definitely diagnostic of a pregnancy failure. So you may have a crown rump length that's 5 millimeters and you don't see a heartbeat and you're kind of like, yeah, probably not, but I can't really say that. So they need to come back and get further imaging in a week or so. And then there's also if there's an empty amnion, so a big amniotic sac adjacent to a yolk sac, but no visible embryo. And then also if you have an enlarged yolk sac, so bigger than 7 millimeters is abnormal and the pregnancy is likely to fail. You can also have calcified yolk sacs, and those are generally an indication of pregnancy failure as well. So some things to keep in mind, and you may want to have this table as a reference because if you're like me, you won't remember it all, but you can look it up before you go and chat with the patient about your ultrasound findings. So just as a little refresher, this is how to measure a mean sac diameter. It's the same as measuring a bladder volume. So you're going to have a plus sign and a minus sign so that you're capturing 3 different dimensions: anterior to posterior, side to side, and head to feet. So it's the same plus and minus that we use for the bladder volume measurement. And as you can see here, this sac should be, you should see a fetus that's 7 weeks and 6 days. The gestational sac is 3.26 centimeters. So this would be a definite pregnancy failure if there's no pregnancy in there. So back to our first case, you can see we have the gestational sac that's 35 millimeters, so clearly exceeding that 25 millimeters, and this is a definite pregnancy failure. So, and this person is actually a couple weeks, later than it looks like this pregnancy probably failed a couple weeks ago. And this is someone that you may want to talk to GYN about how to manage this, whether they want to manage it expectantly or if they want to go ahead and manage it surgically, because the patients become at risk for infection if they've had what used to be called a missed abortion for some time. Okay, regrouping. So we talked about the gestational sac, and now we're going to move on to the fetus. So here we have a fetus. Everything looks hunky-dory, 7 weeks, 5 days, and we don't really notice any movement. And we put our M mode, because remember, we want to use as low as reasonably achievable power for very early pregnancies. This is one of the instances where you don't want to use a lot of energy because it's such a small thing. And we don't see a heartbeat. Now, it's difficult to say, do I really have my line in the right place? Maybe I'm just not, maybe I'm off, so it doesn't look like there's a heartbeat. And this is the one time that it's okay to put color on a small fetus. Normally we don't do this because, again, of the energy with color Doppler. But you really need to prove that this fetus is not viable. And the way to do this is with color, because a normal fetus would light up like a Christmas tree. So if this is getting blood supply, you would see blood from the cord, you would see blood in the heart, you'd see a lot of blood flowing within the fetus. And in fact, your OB docs, I know our OB docs want us to put color on these to really prove that this is a failed pregnancy, so that they're totally comfortable with it. And when you put the color on it, you want to make sure that you get some evidence of flow, like in the uterine arteries and around the gestational sac, to know that your PRF is set correctly and there is actually color flow in the uterus. Okay, moving on. We have a G2P1 at about 8 weeks by LMP with some nausea, some vomiting, and some mild abdominal pain. And this is the transabdominal scan. So you can see that there's a gestational sac or some kind of sac. It looks fundal. It looks like it's, developing nice endometrial rim to it. But there's really no, I could maybe hallucinate a yolk sac, but I'm not really sure. So we're actually going to take a look transvaginally, which is one of the reasons you want to learn transvaginal ultrasound. So this is the coronal view. So the patient's right side is on the left side of the screen. Their left side is on the right side of the screen. Their feet are at the top, and then their head is at the bottom. And we're just going to scan through. Oh, and we see, yep, there's a sac. Oh, wait a minute. A couple of things we should notice about this, though. The first one that should jump out at you, of course, because we just talked about it, is that there is a small subchorionic hemorrhage. So you can see a little anechoic area where there's been bleeding. And the other thing that should jump out at you is that there are 2 yolk sacs. And you can actually see like a little fetus right in here as well. So this is a twin pregnancy. And this patient actually came in on April Fool's Day. And she called her husband, and he would not believe that she had twins. So I had to get on the phone. He thought she was making an April Fool's joke. So I had to get on the phone with him and try and convince him, and then take some pictures for her to take home to him to prove that they were actually having twins. We're gonna take a look at each individual twin. How big are they? What's their heart rate? So we take a look at the first twin, and it's just giving you to a very small crown rump length because it's actually before 6 weeks, so it's not going to tell you how far along it is. And then the heart rate, I don't know exactly why there isn't the actual heart rate on the thing. I may have cut it off on my image. And then the second twin is a little bit smaller, the heart rate's a little bit slower. And, how do I label these? How do I communicate to my OB docs who are going to follow these patients which twin is which, because they're going to have to remeasure them as things go along. And so there's actually a labeling convention. So the twin that's closest to the cervix is going to be twin A, and the twin that's farther away will be twin B. And then, of course, if you had multi pregnancies like triplets or quadruplets, then as they moved away from the cervix, they would each get their own designation so that they can actually be followed during the pregnancy. So this is a slightly more advanced pregnancy, and you can actually see there's a thick chorionic rim between the two pregnancies. And, generally OB wants to know about these pregnancies because they're higher risk. So we see a lot of early pregnancies and they get routine follow-up with OB. But for our twins, we generally like to be in touch with them because they will want to see them in a high-risk clinic and usually follow them much sooner. So your OB consult says, well, what kind of twins are they? Are they di-di, mono-di, mono-mono? And you're thinking, oh, yeah, right. Sure, I remember all of that. So I don't. So, you have to go look it up. And so here's what happens with the development of twins. So you get cleavage, you have the morula, and you get cleavage days 1 to 3. And this is usually 2 eggs and 2 sperm. So they're fraternal twins. They are not identical twins. And you can see that there's going to be a kind of a thick rim of chorion between those 2 fetuses. And they obviously they do not share a placenta. Okay, and then if they're in the blastocele stage, where they have a few more cells, they divide at days 4 to 8. They are typically going to share a chorion, but have separate amnions. So there's 2 amniotic sac, and those are considered identical. And then also considered identical are 2 twins who share both the chorion and the amnion. And the reason this is important is because these twins, particularly the mono-mono, are at much higher risk for bad things to happen. Twin transfusions, getting their cords wrapped around each other's necks, all of that lovely stuff. So they'll be followed super closely. And then if they don't separate until about 15 days, you get conjoined twins. And I can honestly say I have not seen that in my ultrasound experience, but you never know. So this is an example of dichorionic, diamnionic, and you can see that there's this really thick area of chorion between the 2 pregnancies. So these are fraternal. And one of the ways you know it's the chorion is that it has this kind of slope up, this kind of J to it. So that's very typical of the chorion. And generally, they're going to be quite a bit thicker, especially as the pregnancy progresses. And then this is an example of monochorionic and diamnionic. So you can see that there's a small rim. It's bright, it's echogenic, but it's not thick between these 2 pregnancies. So those are going to have they're monochorionic and diamnionic. And then in this case, we have twins that are really close, and there's no sac between them. There's nothing. And you can see how closely together they are. So these folks are going to share a common placenta, and again, they're at much higher risk. And if you're seeing these earlier, it can be very difficult to tell if there's an amnion between them. So if they're at 6 weeks and all you've got is a yolk sac, but if the yolk sacs are really close together, that should tell you that it may actually be the mono-mono version. So just know that because they're at much higher risk for complications. Okay, so we're back to our same patient, version 6. I don't know where we're at. G2, P1, about 8 weeks by LMP with nausea, vomiting, and spotting. And you put and HCG is positive, and you put the probe on, and you're looking at something that looks like grapes in a snowstorm. And you're like, what the heck is that? And think about moles. So mole digging in, they might be invasive, but they're going to make, these little holes in your snowstorm that look sort of like grapes. And this is a molar pregnancy. Kind of nasty looking guy there. They're very rare. So less than 1% of pregnancies. So, and there's 2 different versions. There's a complete mole where the egg has no chromosomes in it, and the sperm has 23. So all you have in this mole is 23 chromosomes, and it looks like the classic bunch of grapes or, the snowstorm. And then you can have a partial mole. So the egg is actually fertilized by two egg fertilized by 2 eggs. No, I think that's not quite correct. Egg fertilized by 2 sperm, so that you get 69 chromosomes. And these are kind of tricky because they might have fetal parts. So there's your complete mole, and then kind of the difference between the complete and the incomplete. This is kind of looks, well, is that a sac? Are there parts in there? Because there's some areas where there's free fluid. There's also a little ovarian cyst at the end of this one that you can see right there. And then this is the sagittal version. And again, it's like, wow, is that a fetus in there? Did it, there's grapes, but there's also these, maybe that's a head, maybe that's an amnion. I don't really know. But one way to tell is, this is the patient where you've been waiting and waiting and waiting for the HCG to come back. You got your urine HCG back, and we know we all start scanning before the quantitative HCG is here. But you're waiting, and you call, and they say, oh, we're still diluting it. And that should be a pretty good hint that this is a mole, because you have an HCG of 400,000. And if this was a pregnancy failure and all you saw was parts of a fetus that was deteriorating, you would not have an HCG of 400,000. You can see HCGs as high as 1 million with these types of pregnancies. So these are really rare, like 1% of pregnancies. And then even rarer is where the mole becomes invasive, and it actually grows into the myometrium. So it becomes like a placenta increta or something like that. Those are super rare. And even rarer is where you have choriocarcinoma, where it digs in and it's actually malignant and it spreads. Typically, you'll see choriocarcinoma spreading to the lungs, but this is like super, super rare. So molar pregnancies, you might see one if you're doing a lot of OB scanning. And then, of course, you need to get your OB folks involved because they need to treat this surgically to make sure that it does not become a nasty mole. Okay, so how about this ultrasound? So we're sagittal, and we can see a nice looking gestational sac. It looks like there's something in it. We have a nice full bladder. And then we go transverse, and it's like, whoa, that pregnancy is way over to one side. And so you should be thinking about interstitial pregnancies, where it's like right up against the corner of the uterus, right where the tube joins. But, that looks like it has enough myometrium around it. It's got, I don't have it measured, but it looks like it might be okay. So you're kind of like, well, why does it look like that? And so we take a transvaginal look, and again, we can see this nice sac here, probably a yolk sac in there. But then you can also see that there's some suggestion of endometrium over here. And that is the coronal uterus or the transverse view. And if we look sagittally, in the midline, where you'd expect the pregnancy to be, there's really nothing there. And there's a little bit of free fluid, anechoic free fluid, so no concerns about that, a small amount of anechoic free fluid. But then, we're looking way over to the right, and you can see that there's actually that nice developing pregnancy. But, it looks like it's got pretty good myometrium around it. So what could be happening here? Well, we have to remember that there are variations on a uterus. Most uteri are normal. They're the normal with 2 horns and 1 fundus, 1 body, 1 cervix. But you can actually have a uterus that's completely got 2 separate uteri where it's didelphus, and there's actually 2 separate cervixes, and you can get a pregnancy in one side. An arcuate uterus just has kind of a little dip into it in the top part. So it's not terribly abnormal, and typically pregnancies do okay. You can have a unicornate uterus where it's just missing that second horn. And you can have the bicornuate uterus. And these are the ones where the pregnancy can get in one horn but not the other. And so it looks terribly eccentric, and you're worried about that interstitial pregnancy, but it's actually just in one horn. And then the other horn just kind of as the fetus grows, the other horn just kind of remains the same size. And you can also have a uterus that has a septation down the middle of it that does not extend, all the way down. So don't forget that every uterus is not the same. These are pretty rare, but you will see them if you do enough scanning. So this is just an example of an interstitial pregnancy on the left, and you can see that the endometrium is right up against the uterine wall. There's no myometrium surrounding it at all. And then the bicornuate uterus, where there's plenty of myometrium surrounding this fetus, and you can see that the second horn is actually there. So definitely something that you will see if you do a lot of scanning. This is another example, and here we have a small sac. It's kind of right in the midline. Maybe it's a little eccentric. And again, these are transvaginal images because we couldn't see anything transabdominally. And you can see the sac is pretty darn small. It's so small I wouldn't really expect to even see a fetus or a yolk sac, perhaps. And then as you scan along, scanning more towards the head, you find that there are two horns. So this pregnancy is actually probably more in the body of the fundus before it's divided off into its separate horns. Just another example where you have a sac in the right horn, but you can see that there's endometrial tissue in that left horn. So most of the times these pregnancies are followed pretty closely early to make sure that they're not an ectopic, an interstitial pregnancy. And then later, they can have complications, but most of them go on to have successful pregnancies. Okay, and we're back to our G2P1, 8 weeks, mild abdominal discomfort, and the urine HCG is positive. And of course, we're not going to wait for the quant because, it's going to take a while to come back, and we don't want to base our ultrasound on doing the quant because if there's an ectopic, it doesn't rise normally. And so all of that, we just want to wait until we have a positive urine HCG. But you're looking around and you do transabdominal, you do transvaginal, and you don't see a definitive IUP. And the history and exam that the patient has given you is just not consistent with the fetal demise. And then there's no concerning findings of ectopic. There's no mass, there's no free fluid with echoes in it to think about blood. The ovaries look normal. And so this is really a pregnancy hide and seek. And this is the one time that we're really going to kind of lean on our quantitative HCG. So we're going to do the transvaginal ultrasound, and going off to the right, if it's a fetal demise that we just couldn't see on our transabdominal, then gyne follow-up, consider DNC or medical management. If there's an IUP and we just couldn't see, the patient still has a lot of pain, think about a heterotopic. So these are pretty rare. I have seen 2 of them, one with a ruptured ectopic or heterotopic pregnancy, and one with a normal 8-week pregnancy, and then also a heterotopic. And neither of these people had any risk factors, and both actually went on to successfully deliver a normal pregnancy after their heterotopics were removed. And if somebody has they have an IUP, but they still have significant pain, you need to be thinking about another cause. So do they have appendicitis? Do they have diverticulitis? There's got to be some other cause of this. Is the ovary torsed? So don't just let it go if they're having a lot of pain and you find a normal pregnancy. And then, no definite IUP. If there's a low HCG, so you're going to wait till your quant comes back. So HCG, it's 1,500, but there's no free fluid. The adnexa look normal. There's no masses. The ovaries are normal size. These are the folks that need a mandatory 48-hour follow-up for a repeat quant. At a minimum, they need the repeat quant And again, search for another cause of the pain. But they need to follow up with OB, or you need to have them come back to the ED in about 48 hours so you can figure out where this pregnancy is going. If they have a high HCG, like greater than free fluid, if they have any, like greater than 2,000, if they have any free fluid, or if they have some funky adnexal mass, you'll want to consult gynecology in the ED, because you want to make sure that they have follow-up arranged, or see what the patient and gyn wants to do, if they want to handle it like it's a pregnancy failure or an adnexal mass, or if they just want to wait and see what happens for a few days. And then, of course, if you see an ectopic pregnancy, you'll call gyn for definitive management, which may be with methotrexate or surgically, depending on the size of the ectopic and whether or not it has a heartbeat. Okay. So hopefully Matt's going to have me back in a couple of weeks, and we're going to go into ectopics and ovaries. So today what we really covered was the progression of the normal pregnancy. We talked about twins, and then we talked about some of the pathology, like the moles, the pregnancy failures, and subchorionic hemorrhage, and what to do if we don't know where the pregnancy is. Any questions, comments from the peanut gallery? And if not, I leave you with the smiley-faced ovary. Oops, where'd it go? Diane's favorite. I don't know if you can see the smiley face. There's two eyes, there's a nose, and there's a big smiley face in the ovary.
Well, thank you, Sandy. That was a great talk, and perfect. Just kind of segue, picking up from the normal that I did, just adding some more. I like what you said, the not quite normals, not quite abnormal, but not quite normals. So kind of one thing building on the next. It's a great way of learning, of just kind of setting that foundation, building the next level, and absolutely 100% we're getting you back to kind of build that third level of some abnormal findings in the first trimester ultrasound. So that being said, any questions from the folks that are on the Zoom call right now vis-a-vis this topic? Or Diane, do you have anything that you'd like to add about the not quite so normal first trimester ultrasound?
All right.
All righty. Well, sans any questions, we'll wrap it up here today. But thank you for joining us for Ultrasound Grand Rounds today. We look forward to having you back in future weeks, either on the Zoom link that you're watching now, or on the YouTube channel that, if you're watching on YouTube channel, you're watching it now. For those of you guys, whether you're on Zoom or on YouTube, be sure to hit that subscribe button. It really helps us out a lot. Just get our message out of what we're doing here and helping inform and educate point of care users around the world about how they can be better with ultrasound. When I was at AIUM, there was a couple interesting talks, and one of them was about it was kind of a research study, but it was a narrative research study about the use of ultrasound to improve maternal outcomes in the first trimester in Kenya. And so it was really fascinating just to look at how what we do here, what we almost take for granted is just kind of bread and butter for us, is something that can have a ginormous impact on outcomes, in a different environment, around the world. And so in this situation, they're using handheld probes, kind of out in these clinics in Kenya, and just doing kind of what we were talking about here, and just, really making a big impact for patients there. So what you guys do matter. Hopefully we can be in support of that and teach you guys more about ultrasound so that you can be even better at what you do. And so with that being said, we're going to wrap things here. We will see you back next time for more Ultrasound Grand Rounds. Thanks, guys. See ya. Bye.